Dr. T.U. Sukumaran, Professor and HOD of Pediatrics, Pushpagiri Medical College, Tiruvalla, and I was the past National President of Indian Academy of Pediatrics 2011, and my special interest is in pediatric pulmonology and bronchial asthma, and I have got my PhD from Mahatma Gandhi University on asthma and environment. In the next 30 minutes time, I will be talking on recent advances in childhood bronchial asthma. As you all know, bronchial asthma is the commonest chronic respiratory problem in children with varying prevalence throughout the country. And this is Pushpagiri Medical College where I am working. And in this talk, I will be talking on prevalence of asthma, genetics of asthma, guidelines for diagnosis and management of asthma, aerosol therapy. I will be touching upon under 5 VCs, bronchial asthma in older children and adolescents. Lastly, I will be talking on prevention of asthma to some extent. And the largest study group which has conducted a prevalence study on asthma is by ISAC study group. And this study group has conducted a prevalence study of asthma in 56 countries, including India. I was the principal investigator of this study group from Kerala. And I have done the prevalence study of asthma in H. block area in Kottayam district. And I have seen that the prevalence of asthma is very high in H. block area in Kottayam district, and the prevalence is more than 25%. As you see in the map, the red star shows the prevalence of more than 99%, and is mainly seen in English-speaking countries like New Zealand, Australia, US, and UK. Almost the same prevalence was seen in Kerala. We don't know exactly what is the reason for this high prevalence of asthma. And these are the studies I have done on prevalence of asthma. And ISAC phase 1 study was conducted in 94-95, which shows a prevalence of 32.2%. Again in 2001, I have done another study in Kottayam with Dr. Vineet, which shows a prevalence of 33.6%. ISAC phase 3 study was again conducted at Kottayam in 2002, which shows a prevalence of 33.64%. And another study done by me at Kochi in Kerala showed a prevalence of 24.4%. And recently in 2014, we have conducted the prevalence study of asthma in 3 districts of Kerala: Kottayam, which is a midland, Alleppey, which is a coastal area, and Idukki district, which is a highland area, which shows that at Kottayam the prevalence was 33%, Alleppey it was 24%, and Idukki district there is a 27% prevalence is there. So all this shows that there is a high prevalence of bronchial asthma in children in Kerala also. Now coming to the genetics of asthma, we don't know exactly what is the type of inheritance of asthma in children. It may be autosomal dominant, autosomal recessive, or it may be multifactorial. Over 51 gene focus have been implicated in asthma and atopy. The paternal genes is important determinant for airway hyperesponsiveness and severity. Chromosome number 11q and 13, first region to be identified for asthma. Chromosome 7 is important for specific IgE. Chromosome 5 for total IgE. There is a gene called ADAM33 gene, which is responsible for airway hyperesponsiveness and remodeling. The skin barrier protein, filaggrin, is deficient in children with eczema, acute severe asthma, and sensitization. In addition, filaggrin will enhance bacterial colonization. Coming to the relation between infection and asthma, you might have heard about the famous hygiene hypothesis or microbial deprivation syndrome. It is seen that those children who are exposed to recurrent bacterial infection in early infancy, they are protected from allergic disorders like asthma. How it works? Normally, in a child, there is a balance between Th2 and Th1 lymphocytes. The Th1 lymphocytes predisposed to allergies, and Th1 will protect from allergies. So, if the child develops recurrent bacterial infection in early infancy, the Th1 level increases and it balances with Th2, protecting these children with allergic disorders like asthma, eczema, etc. Then there is a modified hygiene hypothesis now, which shows that infections like influenza respiratory syncytial virus, rhinovirus predisposed to TH2 stimulation, whereas hepatitis A virus infection, mycobacterium tuberculosis, and measles infection will protect these children from allergic disorders. Our understanding of asthma continues to increase over the time. Initially, we thought the main problem in children with asthma was bronchoconstriction. Then we thought airway hyperresponsiveness is the important problem in children with asthma. Now we know that the asthma is a chronic inflammatory disease of the airway, and if the inflammation is not treated, it can lead to remodeling the airways, which is not reversible. Now, during this time, we know that there are a number of phenotypes, genotypes, and endotypes in the diagnosis and management of asthma in children. Now, asthma is supposed to be an asthma syndrome, and asthma occurs as a result of gene and environmental interaction leading to asthma syndromes with multiple clinical manifestations and phenotypes. And environmental factors are again influenced by demographic factors and social factors. The genes are influenced by genetic ancestry and gene-to-gene interaction. To summarize, asthma occurs as a result of an interaction between gene and environment, which lead to asthma syndrome with multiple clinical manifestations. Coming to diagnostic challenges in asthma, asthma is mainly a clinical diagnosis, especially those children above 5 years of age. There are 3 criteria for diagnosis of asthma in children above 5 years. A child presenting with more than 3 episodes of wheezing per year. And second one is if wheezing is reversed either spontaneously or by using a beta-2 agonist. And third feature is you must exclude other causes of wheezing. You can make a diagnosis of asthma. And investigations are not required for diagnosis of asthma in children. But as you all know, spirometry is the gold standard for diagnosis of asthma in adults. But spirometry can be done only for children above 6 years. Below 6 years, it is very difficult to do a spirometry. In the spirometry, you look for the ratio of FEV1 by FVC. If less than 80%, that suggests that the child is having asthma. Then coming to PFR, that is peak expiratory flow rate monitoring, by using a P meter that mainly helps in monitoring children with asthma. Coming to the various phenotypes of asthma. So these various phenotypes were first described by Fernandez et al. From his famous Tucson study group. And he has reported that there are 3 asthma phenotypes are there. One is the transient early wheezing, non-atopic persistent wheezing, and atopic persistent wheezing. According to Martinez Fernandez, he has described all these features of wheezing phenotypes. And in transient early wheezing, the main mechanism is diminished pulmonary function at birth. The main clinical profile is wheezing during the first few years of life with near disappearance by 3 years of age. The lung function is less than normal. The lung function in later life may remain less than normal. The bronchial hyperreactivity is absent. There are no atopic manifestations, and there is no family history of asthma or atopy. And if you estimate the total serum IgE level will be normal. The second group is called non-atopic persistent wheezing. In this, the mechanism is hyperactive airways, but there is no atopy. The wheezing starts after 2 to 3 years and persists in childhood and early adolescence. The lung function in these children are normal. Lung function in later life is also normal, and there is bronchial hyperreactivity is present. These children have no atopic manifestation, and family history of asthma or atopy will be absent. And if you estimate the total serum IgE level will be normal. The last group is called atopic persistent wheezing. This is almost same as allergic asthma. These children may have hyperreactive airways on an atopic background, and wheezing starts in school years and persists in adolescence and adulthood. The lung function at birth is normal, but later the lung function is reduced, and this may be detectable as early as 3 years of life. Bronchial hyperreactivity is present in this group of children, and they may have atopic manifestations. And usually they have a family history of asthma or atopy, and serum IgE level is elevated. And these children will continue as allergic asthma in later life. There is an index called Asthma Predictive Index to find out the chance of a child developing asthma later, especially those children presenting with recurrent episodes of wheeze in less than 3 years. Martinez has published this asthma predictive index, which consists of major criteria and minor criteria. The major criteria are parents with asthma, second is eczema, inhalant allergen sensitization. The minor criteria includes eosinophilia for more than 4%, wheeze without viral infections, allergic rhinitis, and food allergen sensitization. If there are more than one major manifestation and more than two, these children are more prone to develop asthma later. This is a wheezing phenotype according to the European Respiratory Society, and they have classified this wheezing phenotype into episodic viral wheeze and multi-trigger wheeze. In children with episodic viral wheeze, they will have wheeze in discrete episodes. These children will be well between the episode, and it's most common to see in preschool children. And there is a clinical evidence of viral respiratory tract infection in these children. And these children will present with fever and rhinitis followed by wheezing, and repeated episodes occur seasonally. And in multi-trigger wheeze, there will be triggers apart from viral upper respiratory infection, like exposure to tobacco smoke or exercise can trigger wheezing. They are ephemeral episodes, gets discrete exacerbation but often symptomatic in between the episode. And usually there will be a strong family history of asthma or atopy, or personal history of atopy may be there. And to say something about the prognosis of these children, more than 90% of the children with episodic viral wheeze, they become symptomatic by 5 years of age. Whereas children with multi-trigger wheeze, more than 90% of these children will continue as asthmatic in later life. And this classification is very important because there is slight difference in the management of under 5 wheezes. This is the asthma phenotypes in children above 2 years. You ask, is the child is completely well between symptomatic period? If it is yes, R calls the most common precipitating factor. If it is there, the diagnosis is a virus-induced wheeze. Is exercise the most common or only precipitating factor? If the answer is yes, it's an exercise-induced asthma. And if the answer is no, does the child have clinically relevant allergic sensitization? If the answer is yes, it's an allergen-induced asthma. If the answer is no, it is unresolved asthma. So these are the asthma phenotypes. The children will have a virus-induced wheeze, exercise-induced asthma, allergen-induced asthma, and unresolved asthma. Management of a wheezy child under 5 years of age. Under 5 years of age, the commonest cause of wheezing is bronchiolitis, but children with bronchiolitis, they will not recur. So I will be going to the management of episodic viral wheeze and multi-trigger wheeze. Those children with episodic viral wheeze, acute episodes, you treat with oxygen in severe cases, use oral or inhaled bronchodilators like salbutamol, and steroids may be used in very severe cases if the child has any risk factors. Then multi-trigger wheeze, depending on the saturation, the children should be given oxygen. You must give inhaled or oral bronchodilators depending on the severity, and beta-2 agonist is the mainstay of treatment. Use steroids early on, particularly if there is a personal or family history of atopy or asthma. And these children should be treated as acute asthma. Then coming to long-term management, in episodic viral wheeze, if a child is having frequent, that is say every month or so, or significant attacks affecting sleep or school or feeding, a long-term therapy is indicated. Inhaled corticosteroids have a very limited role, but in those with a very bothersome symptoms, they should be tried as multi-trigger wheeze. And LTRAs may be beneficial, either a short-term or long-term can be given, may be tried in children with episodic viral wheeze. Whereas in children with multi-trigger wheeze, they should be treated as asthmatic. If the patient has persistent symptoms as described in the grading, if persistent symptoms are there, you can have a trial of inhaled corticosteroid, either budesonide or beclomethasone, 400 micrograms per day, is given for 8 to 12 weeks, and it is tapered and stopped. If there is no clear benefit within 4 to 6 weeks of initial therapy, consider alternate diagnosis and therapy. Recurrence of persistent symptom among the respondents justifies reintroduction of treatment as asthma, as discussed above for older children. Long-term leukotriene modifiers are used instead, but they have limited efficacy. So to summarize, episodic viral wheeze, if the child is having recurrent episodes of severe episodic viral wheeze, these children should be put on long-term montelukast or intermittent montelukast. Whereas children with multi-trigger wheeze, if they are having severe episodes or recurrent episodes, they can be treated with inhaled corticosteroid, just like asthma. Then this is the new GINA guidelines 2018 for treatment of asthma in children above 5 years of age. In step 1, no preventers are required. In step 2, the preventer of choice is a low-dose inhaled corticosteroid. In step 3, you can have a low-dose inhaled corticosteroid with long-acting beta-2 agonist. Step 4, you can use a medium dose or high-dose inhaled corticosteroid with LABA. Step 5 should be referred to a asthma specialist, and the child should have add-on drug, like they can have either a monoclonal antibody against IgE, that is Omalizumab, or they can have IgE antagonist, IL-5 antagonist like Mepolizumab or Reslizumab can be added. And the new GINA guidelines, they have added Tiotropium for children about 12 years of age. Coming to aerosol therapy in asthma, aerosol therapy has revolutionized the management of asthma as in adults, but for an aerosol therapy to work properly, it is ideally you must select the correct device for correct age. For 0 to 2 years, you can use a pressurized meteor-dose inhaler with a wall spacer and a face mask. The second choice is a nebulizer. For children 2 to 6 years of age, you can use a PMDI with a wall spacer with a mouthpiece. Again, the second choice may be a nebulizer. For children above 6 years, you must use a pressurized meteor-dose inhaler with a wall spacer and a mouthpiece. And second choice for this group is a dry powder inhaler. So it is seen that at all ages, when you use a meteor-dose inhaler, we must use a spacer to reduce the complications of steroid therapy and to improve the drug delivery to the lung. And always you must discourage home nebulization, because if you use home nebulization without oxygen, there is a high chance for ventilation perfusion mismatch and the saturation may go down. So instead of this home nebulization, you can advise a meteor-dose inhaler of salbutamol. Coming to some of the newer drugs for treatment of asthma. One is Omalizumab. This available Solier is a monoclonal antibody against IgE, and Omalizumab blocks binding of IgE to high affinity IgE receptors on the mast cells and prevents their activation by allergens. It also blocks binding of IgE to low affinity IgE receptors on other inflammatory cells, including T and B lymphocytes, macrophages, and possibly eosinophils, to inhibit chronic inflammation, and it can reduce the levels of circulating IgE. And the main indications of Omalizumab is allergic asthma, and those not controlled with medium dose inhaled corticosteroid LABA in children above 6 years. It is given subcutaneously. The dosage of Omalizumab is depending on the IgE levels. Dose is either 150 or 300 milligram. The main complications are anaphylaxis. So observe these children for a minimum of 1 hour after injection. And there is a high incidence of atherothrombotic episodes in adults who had Omalizumab. And the efficacy of Omalizumab is not studied in 0 to 4 years of age. There is a minimal oral corticosteroid sparing effect is there, but the main problem with Omalizumab is high cost. Other new drug is Mepolizumab. It's a humanized monoclonal antibody against interleukin 5. IL-5 is felt to be the most specific cytokines in eosinophil regulatory pathways. And the new drug is Reslizumab. Reslizumab is another anti-IL-5 monoclonal antibody. It is got similar indication for eosinophilic asthma. A high eosinophil count cutoff based on greater predictive value for sputum eosinophilia. One major difference with Mepolizumab is that Reslizumab requires IV infusion instead of subcutaneous injection that is given for Mepolizumab, and this drug is recommended for approval for children above 18 years. Other noteworthy monoclonal antibodies, Benralizumab. It also targets IL-5. Another monoclonal antibody is Dupilumab, which is directed against IL-4, IL-13 complex. It is designated as a breakthrough drug by FDA. It is effective for treatment of atopic eczema, as well as asthma, and this drug is now entering the phase 3 trial now. Another drug is Tiotropium bromide. It is a long-acting muscarinic antagonist. It is in use for over decades as one of the mainstay of COPD treatment. Asthma recently approved as a second indication by FDA, and it is included in the most recent 2017 GINA guidelines as possible add-on in step 4, step 5, and it is indicated for children above 12 years of age. Another new drug is Oligonucleotides. This augments CD4 differentiation into Th1, shifting the balance to Th1 from Th2 and decrease the production of IgE. Other new drugs are Infliximab, Etanercept, Golimumab, Oligonucleotides, ASMH, 1018 ISS, TLR agents, CRTH2 antagonists like IL-5 antibodies, IL-4 antibodies, IL-9 antibodies, IL-13 antibodies, which are under experimental modalities for treatment of asthma. There are a lot of articles on vitamin D and asthma. Is antenatal vitamin D supplementation prevent asthma later? Vitamin D supplementation will modify asthma risks, and it is need to be proven. So it is unproven now whether antenatal vitamin D supplementation can prevent asthma. More studies are required to find out the effect of antenatal vitamin D for prevention of asthma in children. What is the role of vitamin D in childhood asthma? The Cochrane review offers some protection against severe attacks in adults with mild to moderate asthma. Further trials are needed in children and who experience frequent severe attacks of acute asthma. So further studies are required before you can advise vitamin D routinely for prevention of asthma in children. Coming to the prevention of asthma, is asthma preventable? It is preventable to some extent. You must advise exclusive breastfeeding up to 6 months of age. It is seen that the prevalence of asthma is less in children who are exclusive breastfed up to 6 months of age. And there is an association between vaginal delivery and frequency of asthma. It is seen that there is a high incidence of asthma in children who are born by cesarean section, so promote vaginal delivery. Judicious use of antibiotics in first 1 year of life can prevent asthma, and also judicious use of paracetamol as an antibiotic is required in the first 1 year of life, which can protect these children from asthma. Avoid hyperhygienic environment. Discourage early introduction of at-risk food like milk, egg, peanut, seafood, meat, etc. All these non-vegetarian items should be started only after the age of 1 year. Avoid exposure to animal dander. Avoid exposure to dust mite. And immunotherapy may be useful in children with asthma above 3 years of age. Sublingual dust mite immunotherapy in asthma. Sublingual immunotherapy against human dust mite reduces the severity of asthma, and chronic allergen exposure plays a direct role in exacerbation, and if reduced, modifies asthma exacerbation. And what are the carry-home messages? As I said earlier, the prevalence of asthma is increasing throughout the world, especially in all the English-speaking countries. The prevalence is high, more than 25%. We don't know exactly what is the cause for this one. The diagnosis of asthma is mainly clinical. Investigations are very rarely required for diagnosis of asthma in a child. Spirometry has a limited role because it can be done only for children above 6 years of age, and the only indication of spirometry is in those children in whom you are very doubtful about the diagnosis of asthma. Spirometry may be helpful. Aerosol therapy has revolutionized the management of asthma in children as well as in adults. Phenotyping and genotyping are excellent for optimization of treatment. Those children with persistent asthma should have a long-term controller. Patient education and prevention of trigger factors are very important in the long-term management of asthma. Dear friends, thank you very much for your patient listening. Thank you all.